pathologists. The topic Dr. Jhala has chosen today is on EBUS-FNA and lung tumors, which is so relevant to the current practice. And he will be taking us, through all the guidelines that he has been so much involved in preparation of the guidelines as to how to acquire tissue. Because, lung tumors today are not just morphology, and we have to look way beyond morphology. To chair this session, we have Professor Bharat Rekhi, who is from the professor, and all of us again know he needs no introduction. He is the soft tissue man of India, and he is a professor in the Tata Memorial Hospital, Mumbai. And co-chairing is Professor Nalini Gupta from PGI MER Chandigarh, who will also be moderating this session and taking all your Q&As. And I request all of you to ask all your questions and bombard Dr. Nirag Jhala with all your questions, which will be handled at the end of his talk. And with this very brief introduction, and again, extending a very warm welcome and thanks to all of you who have joined us this evening. It's over to our chairpersons, Dr. Bharat Rekhi and Dr. Nalini Gupta. Over to you, Bharat.
Good evening, everybody, and good morning, wherever in which part of the world you are to watch this very interesting session and talk today. On behalf of the Indian Academy of Cytologists, I'm truly delighted and honored to introduce our very eminent speaker for the Jewel 50 series. As Dr. Radhika has rightly mentioned, a Jewel, Dr. Nirag Jhala, who is a professor of pathology and laboratory medicine at Louis Katz School of Medicine, Temple University, United States of America. Dr. Jhala trained at BJ Medical College, Ahmedabad. He served as a junior faculty at the Gujarat Cancer Research Institute. Dr. Jhala is served as a director of the cytopathology for the Perlman Center for Advanced Medicine for the Hospital of University of Pennsylvania and professor at the Ruth and Raymond Perelman School of Medicine of the University of Pennsylvania, and currently working at the Louis Katz School of Medicine, Temple University. Dr. Jhala's major interests are in endosonographically guided fine needle aspiration and fine needle biopsies. He's made seminal contributions to EUS guided tissue acquisition, which has had a major impact on tissue acquisition from the pancreas and lung tumors. He's been invited by the prestigious NCI to develop white paper on ancillary studies in pancreatic cancer with the use of small needle biopsies. He's been a keynote speaker in national societies and has served in advisory capacity for other national societies. To his credit, he has over 250 abstracts, presentations, peer-reviewed manuscripts and review articles, very inspiration for all the youngsters especially, and has contributed several book chapters, including one of the major textbooks for endosonographers. He's been a co-editor of popular books on cytohistology, focal liver lesions, and 2-volume books of practical interpretation of liver biopsy. It's truly an honor and a pleasure to introduce Dr. Jhala to share his words of wisdom with us today on the topic he's chosen to speak on. Dr. Jhala, the virtual stage is all yours. You can share your screen, please. Dr. Jhala, can you please unmute yourself? Thank you.
So thank you very much for the opportunity given by Indian Academy of Cytology on this Diamond Jubilee series. Thanks to Dr. Srinivasan and all the executive committee members who have provided me this platform today to speak with all of you. This is a topic that is relevant for all cytopathologist practitioners, and I have been involved with it for some time. And I'm just going to share my experience, and I will also love to know about how everybody else does it in different parts of the world. And we will have a wonderful time. Uh, with that, uh, let's see if I can. So I'll cover the introduction and emergence of today's practices and newer technology. We'll talk something about morphology and morphologic mimickers of one or two cases. And we'll talk about how we are utilizing personalized diagnostic in our practices. So we all know gross pathology very well. We all are pathologists. If we talk, when I was growing up, I was told that anything that is hilar will be squamous or small cell. Anything that is peripheral is going to be adenocarcinoma. The world was very simple at the time. Uh, from 1967 till 2004, all the versions of WHO that were created were based mostly on the resected samples, and all the documentation of histopathologic features were identified. The cytology and small tissue sample and its role were not very well documented till 2004. And as a result, we were finding ourselves in a very difficult scenario and the utilization of cytology in our practices. In 2000, and so the recent AJCC or eighth edition of the AJCC classification, they have now incorporated many different variables, including the utilization of imaging in addition to histopathology, and now they've also incorporated the utilization of molecular pathology, immunohistochemistry, and ancillary technologies in addition to small tissue samples. So when we talk about histopathology of tumors, we all are aware that it could be a squamous cell carcinoma with basaloid features or adenoid cystic carcinoma, or major portion being all different varieties and morphologic mimickers or morphology of adenocarcinomas, or neuroendocrine tumors or small cell carcinoma or large cell neuroendocrine carcinomas, as well as tumors with neuroendocrine features. So this is all very well characterized and very well understood. But where does cytology fit into the whole process, and where have we come since 2004? So it's a journey that we all will go through to find out where our opportunities are and how fast we are developing in this arena. So all the time when we talk about cytology and how we acquire tissue, so this was in 1700s when people tried to look into the GI tract or into the bronchus and use these inflexible things to put into either any orifice they could find. So this is something that is going into the GI tract, or there is also cystoscope that was developed utilizing this reflecting mirrors that was present. It was not until the fiber optic technology developed in 1957 when late Dr. Basil Hershowitz uh, allowed this technology to flourish. And that changed the practice parameters, not only for gastroenterology, but also in the field of bronchoscopy, because flexible bronchoscopes are now available. Over a period of time, since 1980s, a high ultrasound transducer is attached to the endoscope, and later on has also been attached now to bronchoscopes. So we'll talk about the endoscopic guidance under ultrasound and the final aspiration portion. My involvement with the endoscopic ultrasound technology began somewhere around 1998. And that was the time when we had seen only the EUS guidance that was available. And we started looking into different organ sites and organ systems, including mediastinum and lymph nodes, and utilization of this technology. And we thought that this is going to be something very powerful, where not only just the pancreas, but multiple other areas that we'll be able to obtain samples from. So according to that, when we started looking into our data, we looked into the mediastinal adenopathy for lung carcinoma staging, and we started receiving a lot of samples from the clinical team. And we said that if we started looking into our sensitivity and specificity, this technology was pretty good. I mean, the accuracy rates of greater than 95% is pretty good. In comparison, when you talk about the transbronchial needle aspirates, then the sensitivity rate and the accuracy rates were not that great, but they were okay. The TBNA at the time did not utilize ultrasound or real-time challenges. Oftentimes, it was just the bronchoscope going in. You extend the needle, and in the dark, you say that this is where the needle will be located, or you use it under fluoroscope and you'll be able to see the guidance. But those were not very, very good methodology to obtain samples. So when we talk about the EUS guidance, uh, our clinical colleagues and especially our thoracic surgeon published whether this will help change the staging of lung cancer. So when they looked at their data and analyzed the assessment of CT guidance at the time, and they said the accuracy for staging for just CT alone was 40%. They added PET to the entire thing, and they said, okay, it increases accuracy even further. Then they said, okay, we'll utilize endoscopic ultrasound and we'll start looking at the node and we'll see if the nodes are enlarged and if we can make the diagnosis and staging can be changed. And in 69.2% of time, the accuracy improved for these cases. So here is just one node that was present in the mediastinum. And you are also seeing this node being aspirated using the endoscopic ultrasound. And with that tissue acquisition, the accuracy rates for staging further improved. So they started talking about it, and the thoracic surgeon said, this is a good modality. When he presented his information to the Thoracic Surgeon Society, they all said that this is well and good, but EUS is only going to sample the posterior mediastinum, so it is limited by anatomy. And that is absolutely true. We all know that when we talk about the mediastinal lesions, we talk about the superior, the anterior, the middle, and the posterior mediastinum. If you put your ultrasound transducer in the esophagus, you will only be able to see or sample the superior mediastinum, the middle portion, and the posterior mediastinum. So most of our pathology will be restricted to the posterior mediastinum. As opposed to that, the endobronchial ultrasound that was developed, and this was developed around 2002 or early 2000s, where they again attach the transducer and the needle comes out at a 20-degree angle, and you are able to sample all the areas that can be accessible by putting the bronchoscope into the bronchus, and therefore the right, the left, and the N2 nodes can be very easily sampled. So when we talk about the regional nodal stations for lung cancers, we can think about the reach by either TBNA or the EUS and EBUS guidance. And all the ones that are in green will be that are highlighted will be approached utilizing EBUS guidance. The subaortic or the AP window nodes are a little difficult to access by the EBUS scope, not impossible. We have our clinicians who are so good that they will also be able to give us the sample from 4L nodes. So that is absolutely fine. The subcarinal nodes and paraesophageal nodes will be EUS guidance, as well as subcarinal nodes or station 7, we can obtain sample utilizing the EBUS scope as well. So this is one of the more frequently sampled node, both by EBUS and EUS guidance. So what are the characteristics or operating functionalities of EBUS? And when they started looking at the EBUS similar to what we found in EUS, they found that the sensitivity and specificity of just a simple CT was not great, but when they added EBUS with fine needle aspiration, the sensitivity and specificity further improved. Here we are talking about the surgical sampling, which is either mediastinoscopy or VATS procedure. Mediastinoscopy is far more invasive and can create a lot of sequelae associated with the surgical procedure and may have complications associated with it. And therefore, over a period of time, EBUS sampling is now considered as the modality of choice. The same thing happened, and this is a paper coming out of the Japanese group, and they looked into different series that were published at the time from 2004 to 2006. They had a lot of patients and pooled samples, and every time you find, the accuracy rates are pretty high. And therefore, EBUS has now become the standard of care to obtain transbronchial needle aspiration from the mediastinal nodes for staging of lung cancer. But just doing that, is it enough? And the answer is that EBUS-FNA had considerable impact in patient management. Oftentimes, when the mediastinoscopies or VATS procedures were concerned, and they provided lung biopsy and they prevented the EBUS-FNA findings. They said this is much better procedure, much simpler, and as a result, they are able to obtain samples from the areas that are not clearly visible to everyone else. So essentially, EBUS-FNA will be able to sample mediastinum or anterior mediastinum and lymph node pathology. It is much cheaper, much safer, much faster, real time, and does not have any complications that are associated with other procedures. So as a result, for the modalities for staging of lung cancer, CT guidance and guided FNA can be performed. It can reach both anterior and posterior mediastinum. The skill level required is very high, but the adverse events are also associated with very high rates. CT guidance FNAs are very good and are still being performed for transthoracic acquisitions. Transbronchial needle aspiration nobody uses it anymore. Most of the centers world over utilizes EBUS guided FNA, which provides you real-time, easy, and safe acquisition for tissues. Only area is that it will be limited by anatomy. Pulmonologists are the mainstay for performing the EBUS-FNA. When we started out in Birmingham, the gastroenterologists were given the prototype needles at the time when this technology was emerging, and therefore gastroenterologists were there to perform the procedure just for couple of years initially, but now they have given that up. The surgeons also have been utilizing this technology very effectively. We often go to the operating room. The surgeon will perform EBUS. We give them on-site diagnosis, and then they will take over from there in the decision-making process, whether to take only the lobe or let the patient go for any neoadjuvant therapies. EBUS-FNA can be utilized. Similar to EBUS, it is also real-time, it is safe, no complications, very cost-effective. But as I showed you, it is limited by anatomy. The main people who perform are gastroenterologists, and in some centers, pulmonologists have also started utilizing it. Effectively, when we use both EBUS-FNA and EBUS-FNA together, it equates to a good mediastinoscopy and can be utilized for stage 3 lung cancers. And this is a nice compilation that was given by Dr. Jain and Sinchita Roy Chaudhary in archives. It's a very nice paper, goes through all different types of collection. If you have bronchial wash, BL, or brushing, it will highlight the mucosal lesions. The transbronchial FNA, EBUS guided, or any other guidance will identify mostly the central locations of the peribronchial areas and the mediastinal lesions, including the lymph nodes. For the transthoracic FNA, where we utilize CT scan more frequently, will highlight the peripherally located parenchymal lesions or pleural pathology. So when we started looking at our EUS and EBUS data, in 2012, we had about 3,000, more than 3,000 cases, and 30% of the time, the lymph nodes were sampled. And in additional slice, you have the mediastinal lesions also that were sampled utilizing this modality. So this has become the standard of care. You also need to know, because when I start teaching the resident, the fellows, and the trainees, and also our pulmonary group, I often have to tell them that what you give me when you say your needle is in the lesion, um, that always is not the case. And with EBUS, particularly because they have to go and sample through the cartilaginous area, the samples are always a little difficult and challenging. But when you understand this part, you also need to understand that on your samples, you may find the bronchial epithelium with cilia on top, and you have this bar. When this falls off, they can create a diagnostic challenge for a novice, because they will be able to see that there is this epithelium or cuboidal epithelium. Some glandular features are there, and if there are multiple of these, then they will start thinking about adenocarcinoma. So one has to be very cautious when they evaluate the samples that are coming through the bronchus. Or when there is squamous metaplasia, the metaplastic cells in the lymph node, if you find them, there is always a tendency to say, well, the patient has a lesion in the lung. Now I'm seeing the squamous epithelium. It could be metastatic squamous cell carcinoma, but at that point in time, one has to hold back and has to think that the needle may have gone through the area of squamous metaplasia. And these are the cells, like any other squamous metaplastic cells, you'll be able to find them. And oftentimes you find this cartilage that will be present in your smears coming from the cartilaginous area here. So don't call this hematoma or anything else. This is just part of the normal content of any evaluation that you see. Based on our 1,000 samples from the lymph node that we found, most of the cases were either reactive lymph node because they were part of the staging process, but we also found significant number of metastatic tumors. We also identified lymphomas. And yesterday I was talking to the GI group that we were able to find mastocytosis or aggressive mastocytosis in a patient with Zollinger-Ellison syndrome in the mediastinum. So you find all different kinds of pathologies and that can go into the mediastinum regardless of where they come from. And oftentimes we have been asked as to how many passes do we need for performing flow cytometry. So we looked at our data onto the thoracic and the intra-abdominal lymph nodes. Our endosonographer and our EBUS pulmonary group was very, very prolific at the time. And when you give them anything, they will just put the needle in and they will be able to give you the sample that you can perform all flow cytometry that you want. And if you have only 2 passes, then you will be able to get adequate lymphoid cells for performance of flow cytometry. So ancillary testing is absolutely possible only with 2 or maximum of 3 passes. So we also looked at on EBUS adequacy by location. EUS, the sampling is good because you go through a muscular tube. With EBUS sampling, you go through you go through the cartilage, and therefore the cartilaginous fragments oftentimes will be present within the needle core, and you may not be able to get adequate tissue sample. So when we looked at our data from 438 cases, we presented this information. About 90% adequacy rates are obtained. We go on site, so ROSE is very big part of our tissue acquisition part, and this also has now been placed into the CAP guidelines that came out in March of 2020, that ROSE is an important component for EBUS guidance. But then also there are centers where EBUS or ROSE may not be possible. So if ROSE is not possible, what do you do? Most of the times, 3 to 5 passes, if you collect it and transport it in the transport medium, there will be adequate samples available. But we also needed to know, because going into the bronchus, the right side is a little straight, the left side will take a turn. And we wanted to know what is our performance if we go to different stations. So if you go to different stations on the right side or on the left side, most of the times we obtained our sample within 4 passes. Oftentimes we reached up to 6 or 7, but no more. But on average, 3 or less passes will get adequate material. But it is also true that while we get the adequate material from these nodes, we also wanted to see which were the areas that were difficult for the pulmonologist to obtain samples from. And for the most part, it was the peripheral nodes, or if you will, N1 nodes are the ones where the difficulty came. One was on the 11L side because it's a little distant and farther away, and also on the 12 and 11R and 12R also together had difficulty in obtaining samples, or inadequate rates were a little higher. Although not as high, not a big number, but still there is difficulty aspirating those nodes. So this is something important, because adequacy based on the nodal status has not been documented very well before. So we just looked at it, and our unsatisfactory rates still are within acceptable ranges. So while we have understood and so nicely identified in the paper by Dr. Jain that if you do the EBUS sampling of the lung directly into the lung lesions is restricted more towards the central zone. There are tumors that are not accessible or are difficult to reach using the transthoracic modality, or using the EBUS modality. They are a little bit further away. So this is a technology that we have used at Temple. You are probably looking at this for the very first time because there are not many machines available throughout the world. In Northeast, there are only 2 machines available, which is the ion navigational sampling for the peripheral lung lesions, where they utilize and do the 3D construction utilizing the CT scan, using the sagittal view. In addition, we also utilize the ultrasound images, and this ultrasound image will guide exactly where the needle should be placed, and the pulmonologist will be able to highlight that area, go up to that lesion, and that is the area that they will be able to sample. So here is just the lesion location that is given in green. Here is where the pathway is created by the machine, that you go this distance, and then at this location you introduce your needle to reach that target. So here is what happens. So when you go in, they are able to go exactly at the location. They will be able to highlight where the lesion will be, and that's where their needle should be targeting. So here is where they will brush the sample before, so that we know that they are not going into the tumor area. When it is negative, they will extend their needle through that area to reach that sample. Now, this is one aspect, which is also the navigational sample. The newer technology will also allow something very similar to the Da Vinci probe kind of thing. They stabilize the needle, and they will provide them a separate channel for the pulmonologist. It's like a video game that they will be able to create. The number of passes that we have about 54 patients that we have identified. The FNA ranges from 2 to 6. On an average, we get our samples within 4 passes. The accuracy rate is pretty decent at this time. False positive we have not given, fortunately, so far. The adequacy rates are not that high because this is a farther away lesion. Technology is new, and we are starting to learn what is going on. It is very safe. It is in real time, utilizes artificial intelligence technology to provide guidance to the pulmonologist, as to where the needle should be introduced. It has a stabilization arm similar to Da Vinci, reaches hard to reach areas, and may reduce the need for transthoracic FNA. This is important because transthoracic FNA oftentimes will give you a lot of air into the pleura. And this particular technology will avoid that portion of it. So this is emerging. You all will be seeing it a little later if the technology performs well. So this is something emerging opportunity for all of us to obtain sampling from hard to reach areas. So when we go on site, we perform a cytology smear. We perform DIFQuick. We also take one for alcohol. We also ask them, as soon as we think that there is a tumor, we ask for additional 3 passes so that we have enough material to perform either immunohistochemistry, or we can perform any molecular testing if required. If we think it is a lymphoma, then we'll collect the sample in RPMI and we can perform the flow cytometry or cytogenetics as necessary. This is the algorithm that was created when we go on site and somebody wants to figure out what we are looking at, then they need to go very quickly from low magnification to high magnification and think about what are the possibilities and collect the sample according to what is necessary. This is published in a book, so anybody can utilize it, and this is available to everyone. Simultaneously, when we looked at the mediastinal mass for the non-lymphoid lesions, and when we started looking at this in 2000 and 2004, we said, okay, these are our tumors that we'll be able to see. And if we collect enough sample, immunohistochemistry can be performed, and we will be able to figure out whether this is adenocarcinoma, squamous cell carcinoma, small cell carcinoma, or any other tumor that can be done. So ancillary testing was available, and many of us were performing it even before the guidelines had changed. So in 2011, because of all these findings that many in the country were performing, the guidelines changed by IASLC, ATS, and ERS, that they said there is now a role for small tissue samples. One should perform immunohistochemical stains to separate out not just small cell versus non-small cell, but on non-small cell, you should go further to say whether it is adenocarcinoma or squamous cell carcinoma. And this was very important because for squamous cell carcinoma, if a therapy is given, and patients with squamous cell cancer will start intrapulmonary hemorrhage, and that becomes fatal for these patients. And as a result, the recommendation started also including the molecular diagnostics for those. As a result of this, the terminology was also an issue. So the new small biopsy cytology and terminology criteria were created for small cell, for non-small cell carcinoma, and how to report these small tissue samples that would correlate with the resected samples for the large tissue biopsies. And for adenocarcinoma, they said if you can find a identifiable pattern, one should. Cytology may not always be great to find all the identifiable patterns. And therefore, if you can just say adenocarcinoma, whether there is mucin component or colloid component, that is fine, but you may not have all the patterns that you can identify utilizing cytology. That may be possible on small biopsy, but not on cell cytology samples. They've also said if you can give a diagnosis of squamous cell carcinoma or favor small squamous cell carcinoma if you cannot do all the time. So essentially, we have gone a long way from calling small cell carcinoma non-small cell carcinoma, where we thought that small cell carcinoma has a chemotherapy, non-small cell surgery. That simplistic model is no longer utilizable. As a result, now we are dealing with small cell tumors or neuroendocrine tumors versus non-small cell carcinoma. And the recommendation is to differentiate adeno from squamous as best as possible. And even further, if possible, you can differentiate from basal to squamous cell carcinomas, or well differentiated tumors to small cell carcinomas. Large cell carcinoma by cytology may not always be possible. So here is just one example where there is no issue with anybody saying that, okay, has this hard cytoplasm, you have wrapping around, you have all these tadpole-like cells, you have the third cells, as Dr. Gupta would start talking about. This is squamous cell carcinoma, no question about it. And if we start looking at what are the features, then the features are nuclear hyperchromasia or membrane variability, coarse chromatin, nuclear pycnosis. In poorly differentiated squamous cell carcinoma non-keratinizing type, you may not find this orangophilia, and you may also find prominent nucleoli. That's not uncommon, so that is a caution for everybody who is looking at the cytology, that nucleoli always does not mean adenocarcinoma. Cytoplasm has sharp edges, and so on and so forth. But when you find things like this, where you find cases like this, where you start to see prominent nucleoli, there is no keratinization, there is some cytoplasm around it hard, and you will be able to see the sharp edges. This hints towards squamous cell carcinoma. And you have this for comparison, the respiratory epithelial cell, right? So this more likely is squamous cell carcinoma. Here, it's very hard to call some adeno versus squamous. So we had looked at it, and actually Charu Deshpande at Penn looked at this, and he said, how accurate are we in diagnosing squamous cell carcinoma in lung cytology specimens? And oftentimes we think that squamous cell cancer is very easy to recognize. So why should there be a problem? So when he looked at the data and presented it to IASLC, these are 200 surge path cases. He found 88 also had cytology samples, and looked at the spread from negative to malignant, and whether there were dysplastic squamous cells present or not. Only in 32 cases, we were able to give a definitive diagnosis of squamous cell cancer. Favor squamous cell or favor some kind of tumor in about 13 cases. And in about 13 cases, we were not sure as to what kind of tumor that we are dealing with. And this came into different specimen types, either in BAL or FNA, and all different kinds of sampling that was created at the time. So when we looked at it, so what were our challenges? So when the malignancy diagnosis was given, in one case, it was called adenocarcinoma, which turned out to be squamous on resection. In the other one, also adenocarcinoma turned out to be squamous cell carcinoma. And squamous cell carcinoma can come in many forms. If you have this keratin pearl, it's easy. But in non-keratinizing squamous cell carcinomas, when you start seeing this nucleoli, and if you aspirate these cells, it is very, very hard. Simultaneously, if you have these basaloid tumors where there is very little cytoplasm, then also it becomes very hard for pathologists or cytologists to separate the two. So when we talk about basaloid squamous cell carcinoma versus keratinized squamous cell carcinoma, there are some differences based on the molecular events. Here, P16 is overexpressed, whereas in keratinized squamous cell carcinoma, there is inactivation of P16, or P53 is inactivated by mutation. Here is P53, where HPV will inactivate the E6 portion, will inactivate this P53. So there are some differences in the pathogenesis of basaloid squamous cell carcinoma versus keratinized squamous cell carcinoma. So how does it impact all of us in cytology, right? So here is one example, history of hemoptysis. And we found these cells where you have very little cytoplasm, does not have any, the nuclear to cytoplasmic ratio is very, very high. We do not see any nucleoli. We don't see anything else. The differential diagnosis here would be whether we are dealing with neuroendocrine tumor. We don't think this is lymphoma because they are getting together. There are no lymphoglandular bodies. So differential diagnosis is neuroendocrine tumor, a lymphoid lesion, or basaloid squamous cell carcinoma. Lymphoid lesion can be easily eliminated, but between the two, it becomes very, very difficult. So if you look at these cells, and if you go around, the publications that have come out have said oftentimes you may find occasional cells with keratinization. So if you find occasional keratinization in cases like these, then one should favor squamous cell carcinoma non-keratinizing type. In cases with small cell tumors, oftentimes it is very hard. Nuclear chromatin pattern may help. Occasionally, this azopardy effect may help. But then you require additional stain to confirm this. There are cytologic features that can help favor one or the other. Here they are tight cohesive clusters, occasional single cells. Crush artifact may or may not be present. And very scant cytoplasm and inconspicuous nucleoli. Both of them will have very similar features. So if we do the additional immunostains, either P53 or P40 will be positive for basaloid squamous cell carcinoma. P63 will have usually it is negative, and TTF1 will be usually positive. And looking at these two, actually year before last, Jan Silverman had given a long course based on all the data that was available, that you can utilize P63 and TTF1 just to differentiate three tumors of squamous cell cancer, the adenocarcinoma and small cell carcinoma, including chromogranin. It is also true that P40 can be utilized, and I believe Dr. Mathur has done one of the earlier studies where not only the cell block, but you can actually utilize, if you don't have a good cell block, you destain the slide and you can use P40 to demonstrate presence of squamous cell carcinoma. So that was one of the early studies, and I think that is very, very helpful, and we have utilized it sometimes to differentiate the two. So when we talk about the well-differentiated tumors and small cell carcinomas, they can have very similar morphology, except that there won't be necrosis and there won't be high mitotic activity. Other than that, the neuroendocrine features could be very similar, but this is easier to recognize in comparison to small cell carcinoma. And immunohistochemistry can be performed. Immunohistochemistry with the HPV-related tumors may have, as I showed, they may have P63 positivity and P16 positivity, and can be utilized to have a poorly differentiated squamous cell carcinoma that can be done. We go on to the non-small cell carcinoma. The squamous cell cancers can be squamous or basaloid. Adeno can be favor adeno, or if pattern can be identified, one should be able to give that pattern, and possibility is there for giving that pattern as well. So when we talk about the adenocarcinoma, you can have adenocarcinoma pattern where possible, or one should favor adenocarcinoma diagnosis. There are all different types of adenocarcinoma patterns that are available. This is the tubular type, and you can always find these cases here. And you'll be able to make the diagnosis of cancer in these cases. This is little rare tumor where you have signet ring cell type adenocarcinomas, and you have the correlates here, where you'll be able to see the mucin in each individual cell, and it's not a difficult diagnosis for cytopathologists. So from here we go to the personalized diagnostic or emerging opportunities for cytopathologists, and we'll be able to see uh, we are in the exciting times for the cancer diagnostics and in medicine. We identify a lot of driver mutations, and targeted therapies are increasingly seen. And as a result, when we say adenocarcinomas, no two adenocarcinomas are very similar. They have a lot of differences in their genomic makeup. And as a result, there is a possibility to offer therapies that will help these patients without creating a lot of toxicities of generic chemotherapies that have been used. So molecular testing can be utilized with appropriate treatment at diagnosis, or when there is failed first-line therapy, you can utilize the other target that is available, or you can do that as a part of the resistance to determine resistance to therapy and change the therapeutic aspects. And NGS can be utilized. Previously, pyrosequencing or Sanger sequencing with individual mutations were utilized. Now we are utilizing this powerful modality of next-gen sequencing. One can utilize the 47 gene panel, and depends upon the type of platform that is utilized, additional information can be gained. But during all these things, it is all important that we communicate with each other. So cytopathologists, how they report, how they make a diagnosis, how they acquire sample, how they triage a sample, how they communicate with the clinical team, and clinical team communicates with them. And all this is important to provide the best care that the patient can get. So how to determine a platform? So if you are only looking at point mutations, or say, for example, ALK4, then you can utilize FISH studies, and you can have the hotspot panels for EGFR and others you can create. It contains druggable targets and has direct clinical utility. The larger panels, if you use the larger panels, you can have hotspot mutations similar to what we do for single mutations or gene mutations for clinical trials. And tumor mutational burdens and MSI can be had with the larger panels that are available. Or one can perform the whole exome sequencing, where you have tumor mutational burden that is becoming very, very important during these times. In addition, microsatellite instability is now also one of the areas where you have immune mediated responses to therapies that can be seen. So MSI is becoming increasingly utilized, or the whole genome sequencing can be utilized to get the mutational translocations or tumor burden mutations, and in the discovery phase it will be helpful. Oftentimes, histologist or surgical pathologist and the clinical team used to say that we do need a cell block, we do need to have a bigger tissue sample, and formalin fixed paraffin embedded samples can be are very good. Oftentimes we have actually documented in the PEN gene therapy group, or PEN group has identified, as well as Sinchita has done a lot of work from MD Anderson, saying that you can utilize FNA, you can utilize cell blocks, but if you have a fresh sample or cytology sample, then it will obtain a quality DNA. There will be no fragmentation, and there is no nuclear deterioration. There is no contamination. You use just cytology sample, and the quality is much better. So if you use the cytology preparations, one can either use the smears, or can use the rinse fluid. We can acquire the sample, put it in the transport medium, and perform analyses. Or one can utilize cell block that is also available for the patients. So when we talk about the smears, there is an advantage that there is immediate assessment of the sample. The cells are intact and the whole nuclei is available for analysis. So the DNA quality is much better. And there is no degradation from formalin fixation. This needs to be validated, but can be done. And you have to sacrifice a slide, but in this day and age, if you do the whole slide imaging and you keep it as your documentation for your regulatory purposes, you can utilize these samples for performing and take the material from the cells. Same thing with rinse fluid. You can use thin prep material, or you can directly send that material for DNA analysis. You have to figure out which fixative that you take this in. So transport medium becomes important, whether it is high saline content versus alcohol-based. Alcohol-based has worked really, really good with many of the centers. So you can use the rinse fluid. And you also can do it through cell block, which we use it for all paraffin embedded tissue. So you can use the tissue rolls, or you can use sectioning depending upon the number of samples you have. So essentially, we can use a thin prep slide or the smears or the cell block. You can pick up the cells from the thin prep smears or anywhere else, and you can scrape it into the rinse fluid, and you will be able to perform the DNA sampling. So benefits of using the next-gen sequencing: many targets in one assay. Same amount of the starting material, but you'll be able to have a lot of hotspots or targeted mutations that can be identified. It will have a faster turnaround time and also can detect rare mutations or variant mutations. So those are the benefits that can be had. So here was a case about 58-year-old male, right perihilar lung mass and lymph node. Prior attempts to obtain tissue diagnosis were CT-guided biopsies, but remain inconclusive. So EBUS-FNA was performed, and a diagnosis of adenocarcinoma was made in this particular case. The diagnosis is not difficult to be made in this particular case. You also have this tumor diathesis. You have this glandular pattern. You have nucleoli. You have the cytoplasm also that goes along with adenocarcinoma. So diagnosis is not in question. So once you make this diagnosis, it's important that we have the molecular testing performed. In this particular case, immunohistochemical stain also supported the diagnosis of adenocarcinoma, negative for squamous. So the pattern was good. EGFR mutation was done, and L8858 arginase mutation was positive, and patient would be responding to the tyrosine kinase inhibitor in this particular case. So here is the data on that, and you have the EGFR mutation that is present. In this particular case, you have it in this location. And if EGFR status is known, one can utilize tyrosine kinase inhibitor, and you find that those who are EGFR positive will have a definite survival or survival advantage in comparison to utilizing a simple chemotherapeutic agent. So when we talk about the molecular marker testings, initially in 2013, only EGFR, ALK4, and KRAS mutations were performed. There were targeted therapies available at that time. Now the choices have expanded exponentially. And as a result, we are also being asked during the therapy if the patient becomes resistant to therapy. And here is one email that I received saying that, Dr. Jhala, I saw that you have made the diagnosis. We're going to have the immunohistochemical stain. We already know the EGFR status. we are looking for T790 activation mutation. So generally, this was done, and this is the communication part, that when you have this kind of communication, you would be able to save the tissue. And I always say tissue management is very, very important for personalized diagnostics, especially for cytopathologists, or when the tissue is very small. So we looked at how can we prevent this utilizing our 221 lymph node FNAs. And we used to have two slides or two sections on a slide, and we said, is it necessary once you give a diagnosis, and if it is required for personalized diagnostics, you want to save as much tissue as possible. So after all the data that was analyzed, we said it doesn't really make a difference if you use any second section or not. So just use first level only for confirmation that the cells are present, and then rest of it can be given for additional testing for T790 mutations. So in this particular case, here was the adenocarcinoma that was seen. And in this particular case, T790 mutation was performed because the recommendation at the time was that you can perform T790 mutation. And utilizing the NGS technology, we were able to find the mutation on T790 hotspot. And the patient did have adequate diagnosis. Similarly, you can do the ALK4 pattern. If it is a mucinous tumor, oftentimes they will be FISH positive, or more frequently, they can have ALK positivity, and you can utilize the break apart probe. Or now in the new panels, you already have the ALK that can be done on the RNA fusion panels. And if we talk about the type of tumor, you can find that the mucinous tumors are often KRAS positive, and non-mucinous tumors are oftentimes EGFR mutation positive. Good part about lung tumors is that if it is one mutation that is positive, so they are mutually exclusive, you won't find KRAS mutation if EGFR is positive. And then comes the time when the immune checkpoint inhibitors were identified, or immune therapies were identified. So starting from 1970s, everybody started looking at the identification of T-cell antigen receptors. In 80s, they identified that they are associated with CTL4 that is present on the lymphocyte. Then came the CD28 and MHC antigen activation association. And in 2010, the PDL checkpoint blockade started showing promise, and the Nobel Prize also went to the person who identified this PDL checkpoint blockade analysis. So anti-PDL antibody started being made. We started recognizing them in 2012. And now, for the first time, FDA came up with Keytruda coming out of Merck, utilizing the C223 antibody on PDL1. And once you analyze the antigen presence on the cell, it can be utilized for patient care and patient diagnosis. So essentially, when we talk about the PD1 and PDL1, the cancer cell and the presence on the T cell, the PD1 will be present. If you give nivolumab, that is from Bristol Myers, it affects the area on the PD1 and does not allow that to interact with the cancer cell, and starts having effect on tumor cells. The same thing with Keytruda will also do the same thing. There are other immune checkpoint inhibitors that are going to inhibit the PDL1 as a marker. And if you do that, the very first trial that was done, that was the Keynote trial, where they looked at Keytruda versus docetaxel in previously treated lung cancer. And they identified that those who were receiving Keytruda had a much better survival advantage in cases with lung cancers. So then came the Pulmonary Pathology Society, and they started looking into all the clones that were available for PDL1. So there are a lot of different clones available. DACO has 22C3. There is the Opdivo trial from Bristol Myers Squibb, which utilized 28.8. The Ventana machine came in and they asked for the clone SP142. So if you use this clone, then the patient trial for the companion diagnostic is a different drug that you have to use. Or if you use SP263, then there is AstraZeneca trial that has come out, and therefore when you want to use PDL1, you have to know which clone you are using, what is the scoring criteria that is going to be utilized, which has helped utilization of the immune checkpoint inhibitors. And these are all companion diagnostics or complementary diagnostic tests. And we have to be able to know whether to score just the tumor or the immune cells that are also associated with the tumor. So based on that scoring criteria, one will be able to use the drugs that are available. The new trials that have come through, there is data coming out that SP142 will also look similar to 22C3. So if you use one or the other, and there is a possibility that you can use either Keytruda versus Opdivo. So in this time and age, when patient is diagnosed with non-small cell carcinoma, there is non-squamous histology, then you do all these tests. If it is squamous histology, you can do EGFR and PDL1. In cases with progression or resistance, T790 mutation is important, and more and more molecular targets are being investigated. The one that is very, very exciting at this time is NTRK 1, 2, and 3. And there are targets available against this particular molecular testing. We also was also asked if I can share our data from cytology lung samples and patients who had COVID associated to them. So we have analyzed about 39 samples in patients who had COVID, 12 FNAs, 25 BALs, and 2 of them were pleural fluids. Most of the times these BAL samples did not show any pathology. We just saw lot of macrophages or pulmonary macrophages. In 2 cases, we saw addition of infection, one with suspected pneumocystis and one with aspergillus, which is what you are seeing something over here. The patient with aspergillus also had another pathology associated with it. This patient had HIV infection as well. And so probably it was concomitant to hit on this patient that we are seeing this opportunistic infection. In cases with FNA, there were 4 cases with tumors. 3 were adenocarcinoma, 1 was squamous cell carcinoma. We did not find any significant pathology in lymph node or on the brushing that were available on these patients with COVID. Most of the times, COVID patients will show in terminal stages the diffuse alveolar damage, and it is difficult to find on cytology samples. Of course, these patients did not do really, really well. Both patients succumbed to the disease, but that was because of the comorbid condition. So take-home points, morphology is the key. We understand the clinical teams, we have to understand them well. We have to have a judicious utilization of IHC, and molecular technologies will help tailor therapies for patients. And with that, I thank you and we'll be happy to take questions.
Thank you, Dr. Nirag Jhala. This was really lucid talk, and we all enjoyed your talk. There have been a good number of questions. To begin with, I would just say that we have a good number of we have a very, I would say, aggressive pulmonologists in our institute, and most of the times EBUS-TBNA we do for sarcoid versus tuberculosis. So recently we've just completed a study where we tried to prepare cell blocks. ROS was done and flow cytometry was done. But the problem which we faced at that time was that the cellularity. Many times in the flow cytometry, we could not achieve good number of events. So that is one. And secondly, instead of EBUS TBNA, I think we do more of pleural effusions for lung cancer, pleural effusions and FNAs, and we are doing EGFR mutations, this ALK rearrangements by IHC, and ROS1 by D4, D6, that is the clone we use. And PDL1, because we have Ventana platform, we use SP263. But the problem in India is that we have Keytruda available rather than the other one, which is from AstraZeneca. So I would like to ask you about your experience of SP263 in Ventana.
Sure. So we had Ventana platform and we did use SP142. We recently changed it to DECO, so we'll have to change over to C223. But important part is that if you have only one platform and not the other,
Yes.
by companion diagnostics, we cannot perform these tests. They have to utilize whichever companion diagnostics that there is.
Yes.
The new ASCO guideline and trials are coming out, which says that since you are seeing similar profile for all four, there is a possibility that FDA will allow additional drugs to be utilized. But at this time, you have to use all four clones at this time, depending upon the therapies that you want.
Okay, sir. So Dr. Dipali has asked which criteria you are using for reporting EBUS TBNA, and is the adequacy based on number of lymphocytes or just presence of pigment-laden macrophages?
Very good question. So the the book that came out by
Yes.
PSC, they start talking about 20 lymphocytes or 40 lymphocytes
Yes.
per high
There is the
power field,
scoring system.
and also you have to see pigment laden macrophages.
Yes.
I've always utilized the concept that it is adequate if I have the target lesion. And if we are talking about whether we have metastasis or not, then 40 is just the minimum number. I generally require more. And if I have that, then I call that as negative. But I still go by whatever has been considered as 20 per high power field. But I call that as most of the times non-diagnostic. If I only have 20, I don't go with it.
So score 1 is inadequate for you.
Yes.
And are you preparing conventional smears also, or it is just LBC and CBs?
No, we just prepare conventional smears, and after we have our diagnosis that is made, or we are saying that it is okay that we have enough material, then we add additional 2 passes for a liquid-based cytology. If a patient is over 40 years of age, we automatically take samples for flow cytometry and keep it, because we won't be able to differentiate polymorphous lymphocyte from follicular center cell lymphomas. So those samples we do send for flow cytometry.
So So Dr. Prerna Guleria, she is asking, are you using are there some tips for suction pressure so that we do not get too many hemorrhagic smears? And Dr. Radhika has asked, how many smears you prepare per case?
So first question on the suction portion of it. I don't believe in getting suction. There are 3 needles available. 19 gauge is the recent addition, but 21 and 22 and 25 gauge are the ones that are commonly used. I do not, when I go on site, I tell them not to use suction. If they want to use suction, a slow pull technique is better in comparison to just having that syringe loaded up and 20 ml syringe will go up and you create that suction. Only thing that it will do is they will be happy that they gave you sample. You will be unhappy because you will get a lot more blood. So suction should not be used. So that was one part. What was question?
So we did a study in which we actually saw the number of revolutions also to be used and the caliber of the needle, and it was seen that it didn't affect too much when it comes to hemorrhagic samples. So the next question was number of smears per case or per pass.
So number of smears per pass is not more than 3. So for on-site evaluation, we just use 1 pass or one slide, and we put the rest of it in liquid-based solution. So we don't use more than one slide per pass on site.
Somebody has asked, EBUS-TBNA is diagnostic tool in assessment of extensive disease, non-small cell lung cancer. Like, do you get some problems when it comes to stage 1B, 2, and 3?
Say that again.
In staging, like when you're doing EBUS-TBNA, I think that will depend on which lymph node is involved. So I don't think that would create a problem, but somebody is asking, EBUS-TBNA is diagnostic tool in assessment of lung cancer staging.
It is a diagnostic tool, depending upon which lymph node there is there.
Yes, sir. Your recommendation regarding cell block preparation. So, do you use needle passes only to be do you which type of cell block you are using preparation?
So for cell blocking, one is that you can do the needle rinses. So
Yes.
3 passes, needle rinses, only 3 rinses. But in addition to that, I ask them to put additional 2 dedicated passes into the transport medium. That was one. The second thing that I do is I have reduced the volume of the transport medium. So previously we used to use 30 mil. I reduced it to 15 mil. And I increase the revolution per minute on the centrifuge. So you reduce the volume, increase the time, and you will have a much better cell palette and therefore much better cell block.
Okay, sir. That's a very good tip which can be applied. Somebody is asking Dr. Sujatha Nathan. They are asking sputum cytology in lung tumors. Your experience on sputum cytology.
So sputum cytology was utilized in 80s, and actually NIH had put in a lot of effort to utilize as a screening tool. And it was, and Dr. Gupta, I don't know whether you all know, but Dr. Prabodh Gupta was one of the PIs on that project from Hopkins, looking at sputum cytology. Since we have all these additional tools available to us, like BAL, washes, the brushes, this day and age, sputum cytology is not utilized as much as a diagnostic modality, because then you have to differentiate sputum from spit, and you have to have 5 macrophages to find the adequacy.
Yes. Dr. Siddharaju is asking morphological clues or tips to identify LC neck. large cell neuroendocrine carcinoma?
So large cell neuroendocrine carcinoma, the tips are very, very difficult to give. One thing is that the cell morphology will be larger. The nuclear to cytoplasmic ratio will be different and will have the neuroendocrine features, but no molding or no crushing, and those
And
things will not.
prominent nucleoli.
Yeah.
Yes. So I think I have come to the last question by Dr. Radhika. She says, do you think with immune therapies coming up, cytology samples can have some limitations?
So PDL1, cytology samples do have limitation, because then you are starting to talk about whether you have enough lymphocytes present or not on the tumors. And because the scoring is differentiated, one is the tumor scoring versus the immune checkpoint scoring. Only if you use tumor scoring, you will have whatever is available. Immune response, you will not be able to adequately assess on cytology samples. So that's your limitation.
Yes.
So tumor scoring will be okay, the others won't.
And your experience for ROS1 in cell blocks, because we have almost done maybe more than 200 cases in which ROS1 IHC was done, but I think only 2 cases are positive. So that's sometimes
That's
frustrating.
some very similar to you. We have even difficulty finding the positive cases for CAP purposes or regulatory purposes.
Oh.
That when we want to have a new platform, then it is very hard to do it.
So, Dr. Aruna is asking, what is the comparative utility of clot core versus cell block in EBUS-TBNA procedures? Can it replace cell block clot core?
It can, but you have to utilize in your own lab and try to do it yourself to figure out what works best in your lab. For
Because now,
us,
yes, sir,
yeah,
sorry.
go ahead. No, go ahead.
It's just that now clinicians have started using those core needles, and you get a lot of these big chunks in your EBUS-TBNAs. So that's why somebody is asking.
So Procore has a two needles. So it has FNA and it has a reverse bevel. So when you come out, it gets you the core. Now, the clinicians are telling you have to look at the worm. Worm can be white and red. And there was a recent paper, I just reviewed one of the papers, and I said that if you only use the white portion and don't use the red portion, which is what clinicians are used to, so that won't give you a good answer. So I asked them to analyze both separately, and what they did when they analyzed it separately, both the components, the red and the white component, had equal number of cells. So don't throw that red part away. Always use it. And I've always said that when you have the core sampling, world over, they are saying that FNB needles will replace FNA.
Yes.
I want actually those FNB needles to be processed similar to cell block rather than histology samples.
Yes.
Because you will have more cellularity if you do it that way rather than utilizing as histology processing.
I think with that, we have come to a question answer round, and I think we can close this session. First of all, I'll thank you for such a lucid talk, extensively covering the topic, and coming up on Saturday evening. For us, it is evening, maybe. Is it your working day today?
No, Saturday is not a working day for us.
On a weekend, it becomes difficult. Thanks to Dr. Nijavan, he is president of IAC, and Dr. Radhika, secretary IAC, for giving me this opportunity to be part of this session. Dr. Mathur silently managing everything for smooth running of this session. Dr. Bharat Rekhi for co-moderating this session. And no session is successful without attendees, and attendees have been regularly writing, like they've consistently writing in chat box. Everyone has praised this webinar, and they're thanking you for this nice presentation. So again, I'll thank all the attendees for attending this session, that too on Saturday evening, and have a good weekend. So with this, I think we can close the session. Thank you, Dr. Jhala. Thank you, everyone else.
Thank you.
Thank you, ma'am.
Thank you very much, Dr.